Hello, my name's Florence. Welcome to the theobspod. I'm an NHS obstetrician, hoping to share some thoughts and experiences about my working life. Perhaps you enjoy Call the Midwife, maybe birth fascinates you, or you're simply curious about what exactly an obstetrician is. You might be pregnant and preparing for birth. Perhaps you work in maternity and want to know what makes your obstetric colleagues tick, or you want some fresh ideas and inspiration. Whichever of these is the case, and for that matter, anyone else that's interested, the theobspod is for you. Episode 33, Investigations. Today I'm going to talk to you a bit about the structure of medical consultations and investigations, tests. Any consultation consists of history, examination, investigations, and management. Management being treatment. This further breaks down. So examination breaks down into inspection, looking at things, palpation, feeling things, auscultation, listening to things. This is standard medical practice, and in this way, a consultation in pregnancy is no different to any other medical examination. As medical students, we learn a structured approach to taking a history. What's the patient or the woman coming to us with? And examination, tailored to the specific system or symptoms that a patient tells us they're having. Taking a history can be a little bit like being a detective. As medical students, our questions may seem long and endless. We have a taught, structured approach. We don't deviate from it. We ask a lot of things that may seem irrelevant or pointless. It may seem intrusive when we ask stuff that doesn't seem directly related to what the woman is coming to us with. But it's necessary. It's necessary to make sure we don't miss important factors, and necessary because we need to start by learning that very structured approach. As we get more experienced, a history gets shorter because as we question, we're sort of sieving the information and thinking what's relevant. And as we go, we're honing our questions to test out possible diagnoses and exclude others. So we start asking questions very specific to the thing that we think might be going on, and asking questions that target and allow us to exclude and discard diagnoses. When I was thinking about this episode, I was thinking about the fact that I was taught in medical school, and older consultants often used to say to me that 80% of diagnoses can be made from history alone. When I started researching this episode, I couldn't actually find any basis for that. Yes, there's a lot online about the fact that lots of people over time have suggested that history may give us 70 to 80% of diagnoses. But I couldn't find any evidence to say that's definitely true. Listening to what a woman's saying, certainly picking up on cues, verbal and non-verbal, are crucial elements of a consultation. If you look at research papers, they then suggest that a further 5 to 10% might be determined by examination. And again, we don't examine the whole body every time we see a woman. We examine the relevant bits. But all this history and examination, sometimes known as clerking in the medical world, means that by the time we've finished, we're getting on for perhaps 90% idea of what might be wrong, what the possible diagnosis is, or what is the diagnosis we need to exclude by doing our investigations. So, having sieved all that information, we're then looking at investigations that either confirm or refute what we think is going on. In pregnancy, we're lucky. Most of the women we see as obstetricians have already been seen by midwives. The so-called booking appointment is when the midwives take a long history, all sorts of information about the woman's medical history, her family history, history of any previous pregnancies. And all that is documented and put into her maternity notes. So by the time I see a woman in my clinic, I've already got a large amount of information there in front of me. She may have come to me because she's got a new symptom or problem, but she may have come to me because during that history, the midwife elicited something that needs some obstetric input. It's different, of course, if a woman comes in as an emergency. Then, yes, we've got all that pre-existing information, but we do need to take a history of why has she come? Has her baby stopped moving? Has she got a headache? Has she got a lot of swelling? So then it's a more traditional history taking. In pregnancy, what are we looking for when we examine? Well, inspection, we want to look for scars. Has she got scars from a previous caesarean perhaps, or other surgery that she's had on her abdomen that may be relevant or make our life more difficult if she does need surgery? We're looking for stria gravidarum. These are stretch marks. We're looking for the uterus, the womb, to be at the expected anatomical landmark. So before we even feel the woman's abdomen, we can tell, does the womb look roughly as big as we expect it to be at the number of weeks she is? For example, the womb should be around the belly button by about 24 weeks. And usually by 34 weeks, we'd expect the womb to be up at the bottom of the rib cage. And at 28 weeks, we'd probably expect it to be somewhere in between the two. We're looking for the linea nigra. This is a line of pigmentation, a vertical line that comes down the belly of the woman in the midline, usually brown, that increases in pregnancy. And we're looking for fetal movements. The baby's movements can sometimes be seen through the skin and the abdominal wall of the woman if she lies down and we look. On palpation, we're feeling the fundal height, so where is the top of the womb, and measuring that with a tape measure. The lie, that means whether the baby's vertical in the womb, what we call longitudinal lie, or transverse, horizontal in the womb, or oblique, diagonal in the womb. Then presentation, so which way up is the baby? Is the baby head down or bottom down? And then how engaged is that presenting part? So has that head or bottom gone down into the woman's pelvis? Auscultation in maternity is listening to the fetal heart. The baby's heartbeat can be heard over its scapula, its shoulder blade. And in the old days, we mainly used a pinard, which was a small metal or wooden trumpet-like thing. So it had a wide circumference that went onto the woman's belly, and then, like a trumpet, it narrowed, like a triangle shape, to a neck, and then a small hole at the end with a plate so we could put our ears next to it. So when you listen with a pinard stethoscope, it's quite intimate. You're putting your ear very close to the woman's belly and listening to the baby's heartbeat, which is lovely. These days, we most commonly use a sonicade. A sonicade is a mini ultrasound Doppler. The advantage of this is that the woman can hear her baby's heartbeat, But the disadvantage is they're often breaking, they're unreliable, the battery's low, or you get background noise. Part of me does think back to the days when we used a pinard slightly nostalgically. It was a really lovely way to hear a baby directly through its mum's abdomen. Let's come on now to investigations. I feel at the start of my career there was a lot more careful thought about investigations. And part of this was if we needed to do a blood test, we needed to take the blood. We needed to get it to the lab by calling porters, and then we had to chase up the results. If we needed a scan, we would have to fill up a request form. We would have to go down to the scan department. We would have to talk to the radiologists or sonographers or phone and have a conversation, explain our thinking, explain our differential diagnoses and reasoning, including what we would hope that the scan would give us information about. And we were very much trained to think, will this investigation change the management? So, will this investigation change the treatment options for this woman? If not, then there's no point doing it. And this was drummed into us again and again. We also didn't have such ready access to tests out of hours. An extreme example from my training might be a ruptured ectopic pregnancy. If a woman came in with classic symptoms and signs of an ectopic pregnancy, that is a positive pregnancy test, perhaps a small amount of bleeding, and a lot of abdominal pain, so that when we examined her, she had signs of peritonism, irritation of the lining of the abdomen, which is when the abdomen goes completely rigid. With that, a high pulse and a low blood pressure, signs of clinical shock. We were encouraged to make a clinical diagnosis and go straight to theatre, not to muck about, not to delay. If you think the woman has an ectopic pregnancy, it's potentially a life-threatening emergency. Go to theatre. And in theatre, in those days, we didn't do lots of laparoscopic treatment of ectopics. In theatre, we were encouraged to go straight to a laparotomy, open the abdomen, that is. That's because in those days, treatment of an ectopic pregnancy was sort of two-stage. You would do a laparoscopy, put a camera into the abdomen to confirm your diagnosis. If the diagnosis was confirmed, you would open her up. We didn't do very much keyhole surgery then. So you would open the abdomen, doing a mini laparotomy. Then you would deal with the ectopic. So you would clamp the tube that was bleeding and probably remove it. But essentially, until you clamped the tube, that woman was hemorrhaging. So if we were convinced of our clinical diagnosis, we were encouraged to go to theatre and not just operate on a woman without tests, but to go straight to the laparotomy. Don't bother putting a needle in and putting a camera in and checking your diagnosis, because all the time you're doing that, she's bleeding. So go straight for it, open the abdomen, clamp the tube, stop the bleeding. And I remember there were a number of times I did this, and there was always that heart in mouth moment. Is my diagnosis correct? Am I going to find a belly full of blood that confirms my diagnosis? Yes, clinically, all the signs point to this being a ruptured ectopic. But am I right? Am I putting her through surgery unnecessarily? You've got to be really confident to make that diagnosis on clinical grounds alone. So you're nervous. Once you've seen a few cases like this, you don't forget it, and gradually that increased my courage. It's an extreme example perhaps, but that way there was no delay in treatment. And although rare, we would hear scary stories of women with suspected ectopic pregnancies being put on the ward with curtains drawn round their bed and then deteriorating behind a curtain, waiting for a scan or blood test. The point was to teach us not to delay, to have courage and believe in our clinical skills and our diagnostic ability. And before you ask, no, I didn't ever take a woman to theatre, subject her to surgery, and find out it was an error. Every time I did, it was the ectopic that I thought it was. Investigations, obviously, are very helpful, but they have their place. I know I might sound old-fashioned in this episode, but I do worry that sometimes investigations can become almost like a reflex, ordered without thinking. A really good example of this is A&E. There's a time pressure after all, the 4-hour target. So when being seen by a triage nurse, blood might be taken and sent for examination, so that by the time the doctor comes to see the patient, the results are available. Super efficient, yes, but what if the bloods weren't needed in the first place? When we receive women from A&E in maternity, they've often not been seen by a doctor, but they've often already had a barrage of blood tests. And I'm not blaming the nurses. Doctors are no less profligate with investigations. We add extra tests all the time because we can, or because we've learnt bad habits from colleagues. One example I see frequently is the trap of constant repetition of a blood test. The initial one may be essential, may prove really helpful in confirming or excluding a diagnosis. But once something's confirmed, then we often continue to repeat the test too frequently. An example I see in my daily practice is on the postnatal ward. A woman perhaps had a larger than average blood loss. We take her blood count. She's anemic. We might prescribe iron. If she's well, there's probably no point repeating her blood tests for a couple of weeks. We need to give her body time to recover. And even then, if she's feeling better, actually, we can be pretty confident that her blood count has picked up. She's not losing excessive amounts of blood after all, and we're giving her iron. But sometimes I see it being repeated day after day. Another example might be a test for infection. We look at the white blood cell count and something called CRP, which indicates inflammation. We might see that her temperature's come down, she's responded to antibiotics, her pulse has settled, and she's feeling better. Maybe we know the source of the infection. Perhaps it's a urine infection, as that's quite common. But we may not know the source of infection, but we can see that her observations, her pulse, her blood pressure, her temperature, her respiratory rate, her oxygen levels, all those are improving, and she's telling us, I'm feeling better. These are the things that tell us she's well, not the numbers. But sometimes I think, particularly as nurses, midwives and phlebotomists take the blood, we can forget that each test is a needle puncture, a needle in the skin for that woman. Do we really need to do yet another test? What is it going to add? Is it going to change what we do? Women can end up with bruises and a hodgepodge of cotton wool balls stuck all over their arms as we attempt more and more blood tests during their hospital stay. We've become disconnected from the physical aspect of what blood taking is. The most interesting thing is sheep-like behaviour. I witness it at handover. Someone says at handover, X woman needs Y blood test. It then becomes separate from how we look after that woman to being a task to be performed, a task to be ticked off a list. It's become separate from the rationale of why we're doing it. It needs to be done. It's on the list of jobs. When I go around the wards, it can be strange. Even if I, as a senior doctor, say to perhaps the midwife, there's no need to take that blood or do that test, it can be really difficult to contradict what has gone before. The woman might be expecting that test, whether it's a scan or blood test. She may have been informed overnight that this is what's needed. So that can be tricky to unpick, give an explanation that changes that expectation, not only for staff, but for the woman herself. Sometimes, even if I contradict the plan, say it's not necessary, I can return to the ward later and find that so strong is the belief that it's needed, it's been done anyway. Another common pitfall is when one orders a test and doesn't look at a result. It's fair enough with shifts, it's difficult, one has to pass things on, and it also can be challenging when one's looking after multiple women at once. But sometimes, even with the best of intentions, I can get to handover and realise, to my shame, that I asked for something on the ward round in the morning and that I haven't yet heard what the outcome was, what the test result showed. Possibly that doesn't matter, because just because I don't know it doesn't mean that the nurse looking after a patient doesn't, or that the junior doctor doesn't. Someone in the team may well know and have followed it up. But it is critical, if you ask for a test, to make sure you look at the result and use it. A common situation I come across is a scan for bleeding in pregnancy. A scan will not usually diagnose the cause of bleeding. If the placenta is low, placenta previa, close to the neck of the womb, and the woman has had antenatal care, then we already know that. If there's bleeding behind the placenta, for it to be visible, it has to be an enormous volume, and usually the woman will present with bleeding or significant abdominal pain or reduced movements. If there's recurrent bleeding, then yes, a growth scan can be useful to ensure that the baby is not being detrimentally affected over time. But if there's a one-off small bleed, a scan isn't going to tell us anything. Yes, it will be nice for the woman to see her baby, but there are other ways we can reassure her about the well-being of the baby by listening to the heartbeat. And given the national shortage of skilled sonographers to do all the scans we need to utilise that resource carefully. Us doing a portable bedside scan to show her baby could be much more useful and better use of resources than doing a full departmental scan, taking measurements. In hospital, access to investigations can be a bottleneck. In the case of more complex tests, if you're not careful, a woman can wait so long for a test that the symptoms and signs she came in with have resolved. Then one has to ask oneself, does she still need that test? Does the fact that she's better exclude that diagnosis? Is it unnecessary to put her through it? And it can be difficult if a woman's been sat in a bed waiting several days for a test to then be the one that waltzes in and says she doesn't need it. Actually, the time spent in hospital has been valuable. It's allowed us to observe her, make sure she and her baby are improving rather than getting worse. But it can be embarrassing and difficult conversation to have. A tricky one to decide is when we're thinking about pulmonary embolus. Pulmonary embolus, a blood clot in the lungs, at its very worst, is a cause of maternal death. Very important to exclude it. But every woman that turns up breathless in pregnancy does not have a pulmonary embolus. In fact, very, very few of them do. The majority may be breathless because they're anemic, because the baby's compressing their lungs, because they have a chest infection, because they're having a panic attack. Any number of other reasons can make them feel breathless. But we're very fearful. We don't want to miss that pulmonary embolus. If we look at a woman's oxygen levels, heart rate, there are clinical ways that we should be able to decide which women are much more likely to have a pulmonary embolus. She's much more likely to have low oxygen levels. If someone's got good oxygen levels and a normal breathing rate and a normal heart rate and a normal ECG, then it's very unlikely, if their oxygen levels are normal, that they're going to have a pulmonary embolus. But sometimes we can become obsessed with doing the test to rule out the diagnosis, because the consequences of missing a pulmonary embolus would be so catastrophic. But the tests that we do to exclude pulmonary embolus, once we've done a chest x-ray perhaps to rule out a chest infection, or a leg Doppler to see if there's a clot in the legs, because that's where a pulmonary embolus would typically come from, then we're faced with either a CTPA, which has a potential future risk of breast cancer, or something called a VQ scan, a ventilation perfusion scan, which has the potential to increase the risk of childhood cancer if she's still pregnant, or advice to pump and dump her breast milk for 12 hours if she's breastfeeding due to radioactive isotope needed. So to determine if a woman has a PE, a potentially life-threatening complication, do you have sufficient confidence in your clinical signs and diagnostic ability to exclude it? Or do you have to use investigations as a crutch to reassure yourself you've not missed anything serious, but knowing that that very test itself carries some minor problems for that woman? So I think what I'm trying to say is that tests are very useful, but need to be used judiciously and thoughtfully. Don't forget the whole issue of power. When we ask for a test, how much do we explain to a woman about our reasoning? I've had women referred to me by midwives because they've been questioning the purpose of a scan or test. It might even be a scan or test mandated by national guidance. The woman sent to me, she doesn't want to have X test. And when I've had a good conversation with the woman, we've come to an agreement about what is and isn't acceptable to them, and what the rationale for the test is, and what are the risks of not having the test. We've met on a middle ground. But it does take a courageous woman to challenge and question why she needs to submit herself to our investigations. We've now reached the zesty bit, the essence, the bit I want you to remember. For every test you perform or request, ask yourself, will this change the treatment this woman is offered? Treat the woman, not the numbers. Look at her, listen to her, examine her, and think, what is the probability that this test is helpful? Is it going to add something? And are you going to make the effort to find out the result and follow it through? Tests are not without cost. Even a simple blood test, a full blood count, the most common test we do, costs the NHS approximately £2.65. And that's just the financial cost. What about the physical and emotional cost of a needle in her arm? And pregnant women listening, what do I want you to take from this? I think when tests are suggested, make sure you understand the purpose, what difference they will make to your treatment or the choices offered. Don't be afraid to ask us, challenge us, make sure that they really are essential to the treatment you're going to receive. Understand why things are being suggested, what the pros and cons are, whether there are alternative courses of action, and is there any downside to having the test, so that you're well informed and you understand what we're aiming to achieve with each and every test that we perform or take from you. So I do hope you've enjoyed listening to the theobspod. If you have, do like, subscribe, or leave a review, and join me again to explore more about the life of an NHS obstetrician. I'm finding it really exciting to have people listening and give me feedback about what they've found interesting. So please do recommend the theobspod to other friends, colleagues, or people who you think might find it interesting. I'd love it if you'd share with me what you've enjoyed about listening and if you've done anything differently as a result. I can be found on Twitter at FW and at theobspod. And please do check the matexp hashtag MATEXP, and the website matexp.org.uk for more information and ideas on how to improve women's experience of maternity care. Finally, I'd like to reassure you that I take confidentiality very seriously, and although I'm talking about experiences from my working life, I'm taking great pains to make sure that I anonymise the stories and talk in more general terms so that I keep confidentiality of my women I currently care for and have cared for in the past very safe. Many thanks for listening.